Hello, hello. Can you hear me? Can you hear me? Okay. Okay. Hello. Oh, I think it's okay. Okay. So I have 1 hour and half. 15? Okay. Thank you. Thank you very much. Good morning. Nice to meet you. Nice to meet you. I stop it. Okay. Hello. I think the guy. Okay. Nice to meet you. Thank you. Yes. Okay. Yeah. Yeah, yeah. Tonight I have the fly at 3:15. Yes, yes. Cargo ready. Right. And tonight there is some dinner event or not? Mhm. Okay. Yeah. Okay. And in the evening there is some event? No. Okay. fine. Nice to meet you. Thank you. Okay. Okay, thank you. Thank you. We can wait 5 minutes. It's better. Okay. Yes, yes. Okay. Thank you.
Okay, good morning everyone again, and welcome back. We move on to the next part of this session for the anticipated topic of implant placement in the atrophic jaw rehabilitation. I'm pleased to announce our next speaker, Dr. Angelo Cardarelli. Dr. Cardarelli graduated with load in dentistry and dental prosthetics from the University of L'Aquila in Italy, 2007. He moved on to specialize in oral surgery at the Sapienza University of Rome in 2010. He is an adjunct professor and tutor at the San Raffaele University of Milan and a scientific advisor to the dental clinic at the Department of the IRCCS of the same university. He is a visiting professor at the University of Agadir. He is a member of the Global Scientific Dental Alliance in Dubai and a member of the International Extraction Academy of California. A speaker in international congresses on implantology and oral surgery, and has authored many publications, one being the book of piezo surgery of impacted teeth. With that, please, I'd like to join you and welcome Dr. Kadrali to start this topic. And yet again, please remember you can ask questions at the end of the session. Thank you, Dr. Kadrali.
Thank you very much. And good morning, everyone. It's a great pleasure for me to be here in Kuwait. It's the first time for me here in Kuwait, and I would like to thank Kuwait Dental Association for having me today discussing this interesting topic regarding the treatment of atrophic jaws with the minimal invasive procedure. Before we start, I would like to introduce myself. I come from a small town in the south of Italy, close to Naples, between Naples and Rome, where I work in my private clinic with my brother and my father. But also, this is my private clinic, they have an operating room for implant surgery and oral surgery, because I think it's very important in our practice to have a dedicated environment in order to perform a good surgery for the surgeons and also especially for our patient. And also I spent some of my time in the north of Italy in one of the best hospital in Europe, the San Raffaele Hospital in Milan, in which we can treat a lot of cases. And during the years, we had the opportunity to increase our knowledge with some of people like Paul Manot regarding, for example, the treatment of atrophic jaws using the all-on-4 concept. So I think it's very important to have a good fellowship with the other colleagues in order to treat correctly our patient. And I'm very happy to announce my new activity, clinical activity and education activity also in Dubai, in this new clinic, in Dona Medical Clinic. So now we can start. As you can see from this publication, these epidemiological studies, in the upcoming years, we will have an increasement of edentulous peoples in both arches. So for this reason, we need to have in our hands a good technique in order to treat this kind of patient, in order to treat old patient, in order to treat patient with some systemic disease, in order to reduce the morbidity and the invasivity, maintaining the same outcomes and the same result in terms of the aesthetic and the function. Because as you know, after tooth extraction, we will have an important bone resorption. As you can see, in the first 6 months, we will have an important bone reduction, especially on the buccal side. So for this reason, we need to have in our mind this concept in order to manage this kind of patient. And as you know, we have different kind of bone resorption according to the quality of the bone. So in the maxilla, we will have an important anatomical structure, as you know, is the maxillary sinus. So for this reason, sometimes we need to treat the posterior side of the maxilla using, for example, bone regeneration. But now, today, I will introduce and I will share with you some cases using an alternative technique to the GBR procedure, reducing the invasivity, using the residual basal bone of the patient, using long implant, using teeth implant with high primary stability, with immediate function and immediate aesthetic. And also, as you know, in the mandible, we have a different bone resorption according to the quality of the bone. And as you know, sometimes, especially in a very important bone resorption case, we need to manage the emergence of the mental nerve. And I will show some cases in which we can use the residual basal bone of the patient without bone regeneration, again with immediate aesthetic and immediate function. So the immediate loading, the occlusal loading is mandatory in order to maintain the bone volume, as you can see from this CBCT reconstruction. After tooth extraction, we will have an important bone resorption in the maxilla and in the mandible with different speed and with different direction. So we will have a centripetal resorption in the maxilla and a centrifugal resorption in the mandible. For this reason, in this kind of the implants rehabilitation, frequently I need to use for the final prosthetic rehabilitation the artificial gingiva in order to keep, in order to maintain a good intermaxillary relationship. So it's very important to know this concept for the aesthetic and for the functional reason. And have a look at this old case in which some colleague placed 12 implants for the full mouth rehabilitation in the maxilla. But as you can see, we have a lot of titanium and few bone. So it's not possible to keep a good vascularization and a good blood supply around these implants. So now we can change this approach. We can reduce the number of implants, especially in the patient, in old patient, in the patient with some systemic disease, in order to reduce the surgical phase, in order to reduce the surgical steps, in order to reduce the biological cost for our patient. So we need to change our mind, and we can introduce a new concept. So we can treat, for example, the full mouth rehabilitation using 4 implants. And I will explain when I need to place the implant with the classical procedure, straight implants or tilted implants, but just to understand how we can change our approach. So we have a lot of bone and less titanium. For example, in this case, 4 implants for over-dental procedure, full digital workflow, reducing the surgical step, reducing the prosthetic step, and we can have this final result, just to understand. Placing 4 straight implants for the over-dental rehabilitation in the patient with diabetes and some systemic disease. But have a look at this case. Sometimes we need to treat this patient in which we have only few amount of residual bone in the posterior side of the maxilla. So now we can treat this kind of patient, reducing the implant, placing a long implant in the posterior side of the maxilla, using a long implants in order to increase the primary stability and in order to increase the contact surface between the implant and the bone. Immediate aesthetic, immediate function, only one surgery, like this. Only 4 implants in order to replace the full arch in this patient with immediate loading, immediate aesthetic, and immediate function, like all on 4 procedures. So as you know, we can place the implant here where the quality of the bone is very high. But according to the original all-on-4 concept, I need to place a long implant in the posterior side because I need to achieve the primary stability in this area where the quality of the bone is very high regarding the maxilla. So using this protocol, we can reduce the surgical time, we can use standard protocol, predictable protocol, according to the age of the patient, according to the systemic disease of the patient, considering always the opposite arch for the final prosthetic rehabilitation is absolutely mandatory. So now we can reduce the surgical time, we can reduce the biological cost, maintaining the same outcomes. And now we can do this approach using the digital workflow, using the intraoral scanner, as I will show later during this lecture, maintaining a good aesthetic and a good result. For example, full maxillary rehabilitation on 6 implants for this atrophic maxillary rehabilitation. And as I told before, in this kind of rehabilitation, I need to use this amount of artificial gingiva in order to maintain a good vertical dimension, like this. And also, it's very important to have this shape of the fake gingiva, flat shape, in order to avoid that the food goes inside between the fake gingiva and the soft tissue. So regarding the maxilla, we have different options. As you know, if we have enough bone in the posterior side, we can place straight implant, as you know. But sometimes we have an important bone resorption in the posterior side. So in order to treat the posterior side of the maxilla, we have a different option: the use of the short implants, the use of the GBR procedure, sinus lift, lateral sinus lift, crystal sinus lift, or we can use the tilted implant. So tilting the implant in the posterior side, we can avoid the sinus, and also tilting the implant, we can reduce the cantilever, and I can increase the length of these posterior implants, increasing the primary stability in order to obtain the immediate restoration. Because in 99% of our cases, also in extreme cases, we can do the immediate restoration, the immediate loading, because as you know, the immediate loading is the best way in order to have a good osseointegration. But in this kind of rehabilitation, we need to keep in our mind different things and different concepts. In this rehabilitation, we can use the residual basal bone of the patient. For example, just to understand the correct approach in this kind of rehabilitation. In this patient, we have this situation, edentulous patient, some residual roots like this. This is the CBCT. But we can treat this patient with the systemic disease, diabetes, alteration of the coagulation, so we need to reduce the invasivity. We need to reduce the surgical treatment. And how we can do it? In this kind of rehabilitation, especially if we have an important bone resorption in the maxilla, we need to find the bone on the palatal side. So I need to find the bone on the palatal side, and in order to do it, I need to use a dedicated surgical flap approach. So in this case, only one surgery without bone regeneration, using this flap, this palatal flap like this, I can increase the surgical view, I can see the bone in the palate, and I can increase the keratinized tissue, translating the connective tissue from the palatal side to the buccal side, exactly like this. So now I can see better the bone, I can place the implant without regeneration, using only the bone in the palatal side. In this case, we have enough bone in the posterior, so I placed the 6-axial implant with the palatal approach. And as I will show later, it's very important to follow the parallelism for the prosthetic reason. So the implant dentistry is a prosthetic discipline with a surgical component. It's very important to understand this concept. So I need to place the implant following the bone for sure, but I need to have in our mind the final prosthetic project in order to place the implant correctly. So the parallelism and the correct implant placement is absolutely mandatory, as you can see, for example, in this case. So 6-axial implant, patient with some disease, immediate restoration at the same time, but it's very interesting to see the healing of the soft tissue only 6 months later. So using this flap, I can see the bone and I can translate the keratinized tissue and I can achieve this amazing result in terms of the soft tissue healing. And this is very important in order to avoid some issue related to mucositis and periimplantitis around our implants. So one surgery, one step, immediate restoration, immediate function, immediate aesthetic, and good management of soft tissue. So it's very important to know this image. As you know, the quality in the anterior side of the maxilla is very high. So we have a very hard bone in this part of the maxilla. For this reason, according to the all-of-4 concept, according to the tilted implants rehabilitation, I need to place the implant in the anterior side where the quality of the bone is very high. And for this reason, I need to place a long implants in order to achieve the primary stability on the nasal basal bone area for the primary stability reason, avoiding the sinus and avoiding the posterior side where the quality is very low. And have a look at this typical case in which you have this female patient. The previous colleague have removed the residual dental elements in the maxilla. So now the patient wants to rehabilitate her maxilla with the fixed rehabilitation, and we have this situation. Obviously, in this kind of rehabilitation, we need to have the CBCT reconstruction in order to understand the thickness and the shape and the quality of the bone. This is the situation at the beginning. It's very important to have a good documentation also for the prosthetic reason. This is the intraoral view. As you can see, this is the healing of the soft tissue 8 months after the extraction. So the previous colleague have removed the dental elements, and now we need to treat this patient. But according to the CBCT, according to the age of the patient and the systemic disease of the patient, also we have the chronic sinusitis in the both maxillary sinus. We have decided to use this protocol, reducing the surgical procedure, using only for implants with immediate loading, and I will show this case. This is the situation at the beginning, the frontal view and the occlusal view. We have a good quality and quantity of the soft tissue, so it is very important during the surgery to manage correctly this soft tissue using a dedicated flap. And have a look at this video about this procedure. This is the situation, as I told before, at the beginning. Then we can start with the anesthesia. And now have a look at the flap. It's very important to start with the flap a little bit palatal, because I need to see the bone on the palatal, because I want to place the implants a little bit palatal in order to keep the bone on the buccal side, and in order to achieve a good primary stability. And also using this flap, this is trapezoidal flap with the palatal approach, I can see better our surgical scenario. So in this rehabilitation, this step is very important. Only if we have a good surgical view, we can go ahead correctly with the surgical procedure. So after that, we can disconnect, as you can see, the palatal tissue is very important. All of my cases regarding this kind of rehabilitation, in all of my cases, I used the conscious sedation. So using the conscious sedation, I can control the anxiety by our patient, but as you know, I can reduce the bleeding, because I can control the blood pressure of my patient. And reducing the bleeding, I can see everything without any problems. So, after this flap disconnection, now we can see better. And according to the treatment of the maxilla, as usual, I used the suture in order to hold the soft tissue on the palatal side, exactly like this. But in the meantime, you can see that also with open flap surgery, I use always free hands, but brain guide surgery and prosthetic guide surgery, we can reduce the invasivity. I mean, we can reduce the bleeding, and we can manage better the soft tissue. And if we have the possibility to manage correctly the soft tissue, we can reduce the edema, the swelling, and the pain for our patient. And I will show the result only after 3 days of this patient. This is the right protocol. Only after that, now we can see the palatal bone, and we can see everything. And according to the CBCT, according to the shape of the sinus, we need to start, and it's very important to follow this concept, we need to start with the posterior implant, with the tilted implant placement, and after with the placement of the anterior implant. Because if I will place the anterior implants before, after that I can change the position of the tilted implant. So, according to the protocol, after this step, we need to follow another step, the ostectomy. And I will show in other case better this concept. So, in this kind of rehabilitation, we need to have the same bone level. So, for this reason, I need to perform the bone ostectomy using the piezosurgery procedure, using the bone clamps. And I use always in the maxilla and in the mandible a simple pencil in order to mark the emergence of the mental nerve, in order to mark the emergence of the anterior wall of the sinus. This is the second step, the ostectomy. In this case, we need to perform a small ostectomy because we have the good bone plane, so only few millimeters of the bone ostectomy. We need to remove some residual soft tissue. In this case, I use the straightened piece and the traditional bars in order to perform this ostectomy, and only after that we have the same bone level, and then we can start with the implant placement. And as I told before, it's very important to know the anatomy of the sinus. Especially in this kind of patient, we can see through the bone, the blue line, we can see through the bone, the sinus membrane, as you can see. So using the pencil and using the CBCT, I can mark the anterior wall and have a look at the perforation on the left side in the sinus. So there is the indication to avoid the sinus in this patient. So I can mark with the pencil the anterior wall of the sinus, and I will follow this inclination in order to place the implant. And obviously, according to the quality of the bone, I need to perform the under preparation implant site in order to increase the primary stability. So this is the first drill. And I will start this implant placement a little bit palatal, following the anterior wall, and I need to feel the bone stability during the implant placement. This is the second drill, and with the second drill we can reach the final length. As I told before, I want to place a long implant, so the final implant here, it will be 16 of length. After that, always I need to check the correct inclination. Only if it is okay, we can go ahead with the next drill. It's very important for the prosthetic reason. And the same in the opposite side. Same approach, same drill, pilot and the second drill to reach the same length, 16 of length. And then we can check the inclination. So only after that we can go ahead with the next drill, a little bit palatal, 16 of length. Obviously, according to the final dimension of the implant, it will be 3.75, and according to the quality of the bone, here we have the quality of the bone is very low. We have a soft bone in terms of the quality, so I will use the last drill, the blue one, on 3.3 millimeter in order to place 3.75 only for few millimeter on the coronal part, and I will show after that. So this is the blue one, only few millimeter, and then we can place the implant. 3.75 and 16 of length. In this case, I used the internal connection with the use, obviously, the multi-unit abutment for the prosthetic rehabilitation. And then we have more than 45 Newton in terms of the stability. We can continue and we can finalize the implant placement using the manual ratchet like this. And it's very interesting to see the amount of the bone that we can keep using this palatal placement. Again, few millimeter, 3.3 for 3.75. It's very important to under-prepare, in this case, the implant side, because have a look at the quality of the bone. So only under preparing the implant site, I can increase and I can achieve the primary stability, because also in this case, I want to make the immediate restoration for our patient using the digital workflow. Only after that, as I told before, we can place the implant in the anterior side. And also in the anterior side, it's mandatory to start this placement a little bit palatal, exactly like this, not in the center of the crest, but a little bit palatal, because as you can see also here, the quality of the bone is not very high, it's very soft bone. So also here we need to under-prepare the implant site, following the same step. Pilot drill, second drill, the use of the pin. So we can do the surgery also without guide surgery, using prosthetic guide, using brain guide, and having a good surgical view. So the first step, so the flap design is absolutely mandatory in order to see everything during the implant procedure. Now the implant placement is correct, so we can go ahead with the next drill. The final implant is the same in terms of the diameter, 3.75 and 13 of length, according to the length of the bone below the nose. This is the red one, and as I did before, using the last drill only a few millimeters to prepare the coronal part, and then we can place the implant. Obviously, it's very important in this kind of rehabilitation using a dedicated shape of the implant, very sharp shape in order to increase the primary stability. Also here we have a good primary stability, so we can do the immediate loading. And it's very interesting to see now the situation of the bone during the implant placement here. It's possible to see the green fracture on the buccal side. The primary stability also in this side is nice. And as you know, the green fracture of the bone, green stick fracture, is a favorable fracture. The buccal side is completely covered by the bone. And obviously after that we can do the prosthetic part using the multi-unit abutment, 30 degree in the posterior and 17 degree in the anterior. And now, after that, it's very important to manage correctly the soft tissue, because I want to increase the soft tissue. So I will use 4-0 resorbable suture in order to close the soft tissue before the impression. Obviously, before the surgery, I did the impression with the removable prosthesis in order to keep the vertical dimension. So I will use the vertical dimension that I did before the surgery in order to keep the same vertical dimension for the temporary restoration. This is the occlusal view, the management, and now we can use the scan body. So we will use the intraoral scanner in order to take the impression, and within 72 hours, within 3 days, we can have the temporary fixed restoration with a good aesthetic and a good result. Only in one surgery, in one appointment for the patient. This is the 3D reconstruction. After that, as you can see, we have no bleeding, because we can check everything, the blood pressure and the bleeding, using the conscious sedation. And then we can send the file to our dental technician in order to perform the temporary restoration. This is the resume about this procedure. I need to see everything. I need to place correctly the implant. So the palatal placement, as you can see on the right side, is mandatory in order to maintain the bone. So I need to have this surgical scenario. As you can see, we have enough bone in the buccal side, in the anterior and in the posterior, because I can see the palatal bone and I can place the implant correctly, preserving the buccal bone. The digital impression, as I told before and as I showed before, within 3 days we can have this temporary restoration with a good aesthetic for the patient is very important, and a good function. So with this digital workflow, within 3 days we can have this temporary restoration, fixed restoration. It's very important in this prosthetic phase to have a good shape of the artificial gingiva in order to allow a correct healing of the soft tissue during osseointegration. This is the situation 3 days before, after the surgery. And this is the X-ray. This is the titanium bar for the temporary restoration. And as you know, using this very long implant, we can achieve the primary stability here where the quality of the bone is very high. Following the anatomical structure, following the CBCT, and using a correct implant placement. This is the situation only 3 days later. Also, regarding the edema and the swelling, we have only a few ecchymosis area, but this situation is only 3 days later. So using a good pharmacologic approach, using a good management of soft tissue, we can have a good result in terms of the post-op result for the patient. So, regarding the maxilla, the important thing is to have a good view. This is another case. Obviously, you can use the surgical guide in order to place correctly the tilted implant, but anyway, it's very important to see the palatal bone and to start the implant placement a little bit palatal. As you can see, different clinical case, but with the same protocol in order to have the same result. Also in extreme case, for example, this is a very challenging case in which we have a huge infection, a huge bone resorption, so we can use a long implant passing through this huge cavity exactly like this, finding the bone on the palatal side. So in the maxilla, it's very important to follow this concept. Have a look. Long implant passing through this huge cavity. Obviously, we can use the bone chips harvested during the ostectomy in order to fill this gap. But we can have a good primary stability also in this challenging case. And it's very important to know the different biomechanism between the straight implant and the tilted implant. The tilted implant can work only linked with other implants. So in the full mouth rehabilitation, we can have straight and tilted implant working together. And the concept is reducing the morbidity, maintaining the same outcomes. And as you know, this concept was introduced by Krekmanov 20 years ago. So reducing the number of implants, we can have a good rehabilitation in the mandible, avoiding the mental nerve, and in the maxilla, as I showed before, avoiding the sinus. Only 4, only 6 implants in order to rehabilitate the full mouth. So using this protocol, we can have a standard protocol, predictable protocol, we can reduce the surgical step, we can reduce the biological cost, avoiding the bone regeneration procedure, and this concept is very important, especially in old patients. So, as I told before, only 4 implants in the maxilla and in the mandible. Obviously, following the emergence of the mental nerve, because we need to, obviously, to preserve the mental nerve, and at the same time, we want to reduce the cantilever. We have also the surgical guide, the all-on-4 guide, for example, in order to place correctly the tilted implant, but anyway, following the anatomical structure, the mental nerve, and the anterior wall of the sinus, we can place correctly, according to the experience of the surgeon, we can place correctly the implants also in this kind of procedure. And this all-on-4 rehabilitation, this rehabilitation with a reduced number of implants, actually is a predictable therapy. And we can treat a lot of cases like this. Patient with some periodontal disease in both arches. This is the situation at the beginning, the lateral view, the intraoral view, the extraoral view of this patient. So he needs to have the rehabilitation in the both arches, but we need to start on the maxilla. As you can see, we have a few residual bone only in the anterior side. We haven't bone in the posterior. We have a huge bone resorption according to the periodontal disease of this patient. This is the short video about this procedure, only for implants. Obviously, in this case, we have an important bone resorption, so we have only the residual bone only in the anterior side between the first premolar to the first premolar from the right and the left side. This is the occlusal view and the X-ray. After teeth extraction, we have this situation, and again, the same flap, as you can see. Different case, but the same scenario. We have enough bone in terms of the thickness. So the same concept, we can start in the posterior using different implant in this case, but using the same protocol, passing through the cavity and placing before the teeth head and after the anterior. In the anterior, we have the post-extractive implant, so we need to start a little bit palatal, and we can feel this residual gap between the implant and the bone using the bone chips harvested during the ostectomy. The immediate restoration, the management of soft tissue, the same concept. So this is a predictable therapy. This is the situation. At the same day, in this case, we used the traditional impression, but actually we use always the digital workflow. This is an old case, but it's very interesting to see the surgical step. Before and after the extraction, we need to see everything like this, and after that we need to perform the ostectomy in the maxilla and in the mandible, and I will show. We have this view, and after that we can place the implant following the anterior wall of the sinus according to the experience, according to the skill of the surgeon, but anyway we can feel the stability of the bone using the first drill, and after that we can use the next drill in order to prepare the implant side. The same things, different implants, different patient, but the same protocol. It's very important to follow this concept. And in this case, I used 4.0 and 16 again of lengths for the primary stability, a little bit palatal. In this case, I used the implant with the conical connection, but anyway, the concept in terms of the surgical protocol is the same. Palatal placement, we need to fill this gap using the bone chips harvested during the ostectomy, exactly like this. Okay? And again, the multi-unit abutment, 17, 13, temporary abutment. In this case, I used the traditional impression, the situation few hours later in the same day, and this is the X-ray. So 4 implants in order to rehabilitate this full maxilla. But it's very important to achieve here the primary stability and below the nose for the middle loading. This is the resume about this procedure, and it's very interesting. So for this reason, it's very important, the ostectomy and the management of soft tissue, because we need to have this result. This is the situation after 4 months. So between 4 and 6 months, we can remove the temporary restoration, we can check everything, and we can take the impression for the final restoration. But we need to wait at least 4 months, especially in the maxilla. And then for the final, I used the digital workflow as usual. And this is the final restoration. 4 implants for the full arch rehabilitation. As I told before, it's important in this case to have this amount of the artificial gingiva in order to avoid the anesthetic result of long teeth. So this amount of the fake gingiva in this case is mandatory for the vertical dimension reason. And this is the final restoration, screwed restoration, like this. Okay? So the ostectomy and the same bone level that we can have using the ostectomy during the surgical procedure. This is the final view, and the lateral view at the end of our rehabilitation. Obviously, after that, we need to treat also the mandible. But anyway, it's very important to understand how we can treat this kind of patient, reducing the number of implants and reducing also the surgical step, maintaining a long-term survival of our implant. This is the final result. The situation before and after the rehabilitation. So this is surgical orthopedic rehabilitation because we have this amount of the artificial gingiva. And we can test the muscle force using this electromyography in order to check also the occlusion. And as you can see, we have a good balance between the right side and the left side, so we can follow this electromyography during the final phase in order to check also the occlusion of the patient. And this is the final X-ray. So only for implants in order to have the full mouth rehabilitation. Obviously, using this case, we can treat, for example, in the hospital, very challenging case in the same time. So we can treat both arches in only one surgery, using only 4 implants in the maxilla and 4 implants in the mandible. This is the situation few hours later, both arches using this procedure. And in the mandible, which is the right surgical protocol. As I told before, we need to follow the emergence of the mental nerve in the mandible rehabilitation in order to tilt the implant and in order also to reduce the cantilever. As I told before, for example, this is 82 years old patient in which we can place only 2 implants to fix the removable prosthesis, but it's very interesting to see, to understand the importance of the ostectomy before the implant placement. Obviously, sometimes we have this shape of the crest, and it's not possible to place the implant here. So the ostectomy, especially in the mandible, is mandatory. And for the ostectomy, we can use different instruments, like, for example, piezo surgery, 82 years old patient, so a small flap only for 2 implants. A small flap, I want to reduce the bleeding, and I want to perform the ostectomy using the piezo surgery, because with the piezo surgery, with the cavitation effect, I can reduce also the bleeding. And I can have this precise section. So only after that, we can place the implant correctly. So just to understand the importance of the ostectomy in the implants rehabilitation in the atrophic jaw. So now we have a correct implant placement, 2 implants at the same time. This is an extreme atrophy, and as you can see, we have the apophysis geni. So the ostectomy is mandatory in this kind of patient. For example, in this case, old patient, obviously, in this case, this is the amount of the ostectomy that we need to perform. I need to remove this amount of the bone in this kind of rehabilitation, exactly like this. So don't forget to perform the ostectomy like this in order to place the implants at the same time. In the simple and, as I will show later, in the complex rehabilitation, for example, like this. 75 years old patient in which we have some residual dental elements in the mandible. So now I want to share the protocol using the tilted implants in the mandible. I showed the protocol in the maxilla. Now we can treat the mandible. So this is the situation at the beginning. And as you can see from the CBCT, the bone, especially in the posterior side of the mandible, is very thin, and also we have a superficial emergence of the mental nerve. This is the situation, the occlusal view, the situation before the treatment, and now we can see this short video. Also, this surgery has been done in general anesthesia. As you know, the bleeding is very low, because I can control. After that, using the pencil, I want to mark the emergence of the mental nerve, because I can see the emergence during the implant placement. After that, I need to perform the ostectomy, and only after that I can start the implant placement. And the emergence of the distal implant should be on the top of the emergence of the mental nerve. So for this reason, I need to mark the emergence of the mental nerve exactly like this. So this is the mental nerve, this is the emergence of the distal implant. And then we can prepare the implant site in the anterior side. Also in this case, the primary stability is enough in order to perform the immediate restoration. Same concept, digital workflow. And this is the temporary restoration only 3 days later. And have a look at the healing also of the soft tissue, only 3 days later. So, from this view, we can have, after the flaps disconnection, this view. It's not possible to place the implant here because I need to remove this amount of the bone and I need to see the emergence of the mental nerve. So I need to remove this quantity of the bone and I need to see the emergence of the mental nerve. So this is the free hand surgery, but brain guide surgery, because I can see everything and I can reduce the risk to injury the anatomical structure like this. Because now I can see the mental nerve. And I will use the mental nerve as a point in order to place the distal implant. This is the occlusal view before the ostectomy. And as you can see, also on the mandible, I need to see the lingual bone exactly like this, using the suture to hold the soft tissue here. And it's very interesting to see the bleeding of some intra-alveolar artery during the ostectomy, like this. This is an interesting picture. But it's very interesting to see the ostectomy performed using, in this case, the straightened piece. Now we have a good bone level, and then we can place the implant. 4 implants for full mouth rehabilitation. This is the occlusal view, starting a little bit lingual because I want to keep the bone on the buccal side. The management of soft tissue, because I want to increase the keratinized tissue during the healing. And this is the temporary restoration, only 3 days later. And also the healing and edema is very low. You can see the fibrin 3 days after the surgery. And this is the temporary restoration in PMMA with digital workflow, with good aesthetic and good function for our patient. But have a look at this complete case from the surgery to the final restoration. Femur patient in which we have this situation in the mandible and also in the maxilla, but now we need to treat the mandible. As I told before, it's not possible to place the implant before the ostectomy. So for this reason, we need to follow always the protocol. This is the X-ray before. Obviously, we need to have always the CBCT. So in our mind, we need to perform this kind of ostectomy in order to change the bone shape exactly like this. And then we can place the implant like this, 2 straight and 2 tilted, following the emergence of the mental nerve. This is the situation at the beginning. We have the removable prosthesis, the hopeless residual dental elements in the anterior side. This is the situation after flaps disconnection. Different case, the same surgical scenario. No bleeding. We can see the emergence of the mental nerve. We have this residual bone cavity after the extraction. And I think there is a short video about this procedure. okay? Also, this surgery has been done in conscious sedation with the anesthesiologist, because again, using the conscious sedation, we can control the blood pressure and we can reduce the bleeding, and we can see better during the surgery. So after the extraction, we can perform our surgical flap, trapezoidal flap with 2 vertical incisions, avoiding the emergence of the mental nerve, like this, with 2 distal incisions in the posterior, and then we can start the disconnection, starting before on the lingual side, like this, holding the soft tissue with the clamps, and then on the buccal side, we can remove obviously the soft tissue after the extraction, okay? This is the lingual flap, and then we can disconnect the vestibular part, like this, obviously full thickness flap. Now we can see the emergence of the mental nerve, as you can see. And the same on the left side. So with the full thickness flap, we can check the mental nerve without any problem in terms to the injury of the mental nerve, and then we can use the suture to hold the same that I did in the maxilla, we can do in the mandible to hold the soft tissue. We can remove some residual roots, and then we need to perform the ostectomy because I want to have a good bone level. So in this case, we have the residual root, but I prefer to remove after flap disconnection because I can see better everything. Now we can go with the ostectomy. Using the bone clamps, we can recover also the bone that we can use after the surgery to fill the gap between the implants and the residual socket, and then using the straightened piece and the bars, protecting the lingual side using the periostele, we can go ahead with the bone ostectomy. We need to reduce the amount of the bone in order to have the same bone level for the implant placement. And we can use, for example, the ceramic bands in order to reduce the vibration. This is another option. This is the straightened piece with the ceramic bands. This is a very precise bone cut, as you can see. So we can see the emergence of the mental nerve, so we can protect here the mental nerve. Now we have a new bone shape, okay? Only after that we can start the implant placement, and I will start with the first drill on the posterior side on the top of the emergence of the mental nerve, because I can see, and using the inclination I can avoid the injury of the mental nerve. The same on the left side, using the emergence of the mental nerve to start my implant placement with this direction. Like this, we can check everything. We can check the inclination as I showed in the maxilla, the same concept, and then we can go ahead with the next drill. In this case, I used another branch in terms of the implants, but as you can see, the protocol is the same. Obviously, in the mandible, it's different in terms of the under preparation because the bone is very hard. So sometimes we need to use the last drill for the full length according to the quality of the bone. But the surgical procedure, it's the same in terms of the surgical step. This is the next drill. But as you can see again, this is a very safe surgery because we can see everything and we can control everything without problems. We haven't bleeding, so we can see everything. We have a good management of soft tissue, so we can keep the periosteum, we can reduce the edema, the swelling, and the pain for the patient. And I think this is the last drill according to this kind of implant. This is the last drill, I think, only for a few millimeters like this in order to prepare the coronal part. And then we can start with the implant placement. In this case, I used 13 of length and the 4.0 of diameter. The emergence is on the top of the mental nerve. In this case, I used the implant with the conical connection again. But anyway, it's very important to see the protocol, not the implant's brands. I think it's very interesting to follow the protocol. Again, the same on the left. Okay. And only after that we can prepare the anterior. And also in the anterior it's very important to start touching the lingual bone in order to avoid the fenestration on the buccal side. So I need to start the preparation touching the bone on the lingual bone side, exactly like this. Otherwise, if I will prepare in the residual socket in the center of the cavity, we will have the bone fenestration after the implant placement. Again, checking the parallelism using the pin is very important, like this. Obviously, if you have a not correct implant placement, also for the prosthetic part, we can have some problems. But if we can check everything, and if we can control everything with a good implant placement, we can reduce the risk to have some problems during the prosthetic part. And using this implant placement, touching the lingual bone, as you can see, we can preserve the bone on the buccal side after the implant placement, exactly like this. Touching the bone on the lingual side, don't touching the bone on the buccal side. And then I think we can place, this is the last drill, and then we can place the implant according to the implant that you want to use. We can go ahead, and then we can place the implant like this. It's very important to keep the pin also during the implant placement in order to follow the same direction, the same inclination. And as you can see, we have 2-3 millimeters between the implant surface and the buccal bone. High primary stability, as you can see. And the implant placement before the use of the multi-unit abutment in the mandible, according to the inclination, usually we can use the straight multi-unit abutment in the anterior and the 30 degree, in the posterior, according to the inclination. This is the 13, like this, okay, in the posterior, and this is the occlusal view after the prosthetic part, using the healing cap on the multi-unit abutment to manage the soft tissue. And then we can take the impression, using now have a look at the ostectomy, good bone bone level using the digital impression as usual. Obviously, reducing the bleeding is very important also after the surgical procedure, because sometimes if we have the bleeding, we can have some problem during the impression, especially using the digital impression. So if we have the possibility to reduce the bleeding, is better, especially also for the prosthetic part. This is the digital impression. The resume about this procedure, the occlusal view, the multi-unit abutment, the emergence of the mental nerve, as usual, the soft tissue management, and this is the temporary restoration 3 days later, according our protocol, using the digital workflow. This is the situation 3 days later. Have a look at the healing of soft tissue. I use always the resorbable sutures. And this is the situation only 3 days later. The X-ray post-op with the temporary bar inside the temporary restoration. I keep this dental element during this procedure in order to have a good vertical dimension, in order to protect also the occlusion. But I will remove after. This is the situation before and after the temporary rehabilitation. So now we need to wait 4 months, and this is the healing of soft tissue. And after 4 months, we can go ahead with, this is the occlusal view. We have a good protection of the keratinized tissue. We can go ahead with the final restoration, screwed restoration without gingiva in this case, like this, screwed. And this is the situation, the final restoration, and the X-ray post-op. Obviously now, and I removed the molar. So as I told before, don't forget this concept. The implant dentistry is a prosthetic discipline with a surgical component. Why? Because sometimes we can have this problem. Have a look at this patient, in which the colleague placed 3 implants with the removable prosthesis probably, but as you can see, the implants are also integrated, but the position is completely wrong. It's not possible to keep these implants. So, following the bone, but not following the prosthetic project. Have a look at the situation after I removed the prosthetic part. Have a look. Okay? Obviously, we need to remove. And we can place small flap, 1 surgery. I removed these 3 implants like this, and I placed another 3 implants on the left side. Obviously, I placed another 3 implants in the right. But it's very interesting to see the situation on the left side. This is the previous implant placed from the colleagues, following the bone, following the wrong way. But if I have the possibility to see the bone with a good flap design, I can reduce the risk to place the implants here. So after implants extraction, I placed 3 implants here, a little bit palatal. I removed using a dedicated tools in order to reduce the trauma during the implant explantation. And then I placed the multi-unit abutment, but here I want, this is the temporary restoration, I want to manage the soft tissue because we haven't keratinized tissue, especially on the left side. So in this surgery I want to place the implant, but I want to change the keratinized tissue. And this is the healing 4 months later. This is the new keratinized tissue only using the palatal translation, and with only one surgery. The digital workflow again, but it's very interesting to see this new shape of the arch. Here we have the new soft tissue. I don't know. Here, the new keratinized tissue and the correct implant placement, considering the previous implant placement in the fornix. And then we can go ahead with the final restoration with the artificial gingiva, and this is the final restoration in this patient. So the prosthetic part is the final X-ray is mandatory. In all cases, in this patient, we have in the mandible enough bone in terms of the thickness and the length. So we can place, in this case, 6 straight implants. It's not necessary to tilt the posterior implant. This is the situation at the beginning. Have a look before the surgery. Sorry, we have this situation. We have a good quality of the keratinized tissue. But as usual, I need to see, and I need to change the bone shape. I want to see the emergence of the mental nerve. I can see everything. I can see the thickness of the bone. I can see the lingual part using this flap as usual. And we can place, without surgical guide, but following the anatomical structure, seeing everything, using a correct flap, 6 axial implant, a little bit lingual, following always the parallelism. But it's easy because we can see everything, using this flap and having this surgical view. And then we can perform also, in this case, the immediate restoration, obviously, using the immediate loading. But again, have a look, the management of this amount of the keratinized tissue, because I will show the healing of this case. Temporary, 3 days later. 3 days later, we have this situation. Have a look, the quality of the soft tissue only 3 days later. So we have the condition in order to have a good healing of soft tissue. 6 axial implant, easy case in terms of the bone thickness and the bone height. Temporary, but have a look the healing 4 months later. This is a good healing, new shape of the arch. And have a look the occlusal view. 1 surgery, temporary restoration, digital workflow, good management of soft tissue, and good implant placement. These are the important things in edentulous maxillary and mandibulary rehabilitation. So we have the nice condition in order to go ahead with the final restoration. And this is the final restoration, like this, screwed on 6 implant with an amount of the fake gingiva in order to reduce the length of the teeth. But it's easy case if I will follow the right protocol. And now at the end of this lecture, I want to show this an interesting case, because sometimes we need to treat this kind of patient in which we can keep some dental elements and we can solve at the same time a huge problem like this. We have a huge infection in this 72 years old patient. He doesn't want to remove all residual dental elements, so now we can keep the right side and we can treat the left side. But as you know, we have a huge infection and a huge bone resorption on the left side. So we need to plan correctly this patient. Obviously, in this case, we can't do the immediate loading, but we can keep these residual dental elements. We can remove the hopeless residual dental elements, 72 years old patient, so we can reduce also the invasivity. Small flap, removing the infection, putting inside the heterolog bone, like this, covering using double layer of collagen membrane fixed with the pin. This is the residual dental elements that I removed, and using the horizontal mattress. So also the suture, as you know, is very important. In this case, I want to avoid that the soft tissue goes inside. So now we need to wait. We can make the temporary rehabilitation for this patient, but we need to wait. This is the X-ray post-op. As you can see, we have the pin here to fix the membrane. But have a look at the healing. Obviously, in this case, we need to wait at least 9 months before the implant placement. But have a look at the healing of the soft tissue. And after 9 months, we can open the flap. We can see the new bone, and we can see also the pin. And as usual, considering that now we have a new bone, we can place 4 implants, straight implants in this new bone. Like this. Also in this case, I performed a little bit of ostectomy. This is the occlusal view, but have a look at the quality of this new bone. Okay? And then we can place 4 straight implants, but again, following the correct implant placement, following the correct management of the soft tissue around the implants. So this is the situation before and 9 months later. Again, the parallelism, the correct implant placement is mandatory. And then again, full digital workflow, management of soft tissue, digital impression. So small surgery also in this case, small GBR, small flap, but it's very important to manage correctly the soft tissue and to place correctly after the healing the implant. After that, it's very easy to have this kind of the temporary restoration with an amount of the fake gingiva in order to wait the healing. So now we have a new bone. At the same time, I placed the 1 implant here after the orthodontic treatment with immediate restoration. But anyway, we have 4 implants in this new bone. So if we have enough bone, we need to place the straight implants. There is not the indication to tilt the implants. But again, different clinical case, same protocol, same result in terms of the soft tissue healing. Have a look at the healing of soft tissue only 4 months later, like this. Is very important for a long-term survival of our implants. Regarding the implants rehabilitation, the tissue is the issue. So we need to manage the soft tissue correctly during the implant procedure in order to have a good healing and in order to protect our implants during the years. And we have several publications about the use. This is one publication with my university and hospital in Milan using the alternative of maxillary sinus using the tilted implant. So this is actually a predictable therapy. Minimal invasive approach using another publication with San Raffaele University using a reduced number of implants. Obviously, we need to follow the protocol. And as you know, actually, we have another option, the zygomatic implant, but is out of our topic today. But I would like to introduce our our new textbook with Arun Gan from Miami University, in which you can find another option about the treatment of the atrophic jaws using the zygomatic implants. So thank you for your kind attention. I think we have in time. Okay, and if you have any question, please feel free.
Thank you, Dr. Kader Ali, for the very informative and well-presented lecture. I would ask the audience if you have any questions. Mic to the front, please.
Good day. Thank you for this awesome presentation. This is Dr. Faiz from a private clinic in Kuwait. I would like to ask you about how do you register the bite using the scan body after you took the impression?
Sorry, how?
Bite registration. You placed the scan body, then you took the impressions. How did you take the bite?
Yes, as I told, this is a right question. Obviously, in this kind of rehabilitation, if you have the residual dental elements, you can take the impression with the residual dental elements in order to keep the same vertical dimension. But in the edentulous patient, you need to use before the surgery, and we need to take the impression before the surgery using a removable prosthesis as model in order to scan and in order to have this vertical dimension for the for the temporal registration. Okay? So you need to use the temporary, the removable prosthesis in the edentulous patient as model to register the vertical dimension before the surgery. Otherwise, it's not possible to register the bite.
Any more questions?
Very rich lecture, many thanks. I want to ask about the contraindications of all-on-4 technique. I mean, when I have like 8 or 10 millimeters for the posterior implants, I'm still I can still put all-on-4. Sometimes I have aggressive periodontitis, very old, weak patient. I would like to consider all the force factors, but if I have like 8 millimeters, the height for the posterior implants, can I do?
Okay, so basically we have the indication and the contraindication for all-on-4. Obviously, if you have a young patient, you need to perform the GBR procedure. You need to avoid the all-on-4 procedure, okay? Young patient, healthy patient, we can do sinus elevation, bone augmentation, Curie technique, using the bone harvested from the posterior side of the mandible. If you have old patient, I mean from 65 years up with some systemic disease, we can use the all-on-4 concept. Instead, the short implant, do you mean? Because if you have the possibility to place 4 implants and long implants in the posterior, it's better than to place a short implants in terms of a long-term survival. Okay? So it's better to have a long implants, tilted implant, reducing the cantilever. The option of the treatment of the posterior side of the maxilla and the mandible are different. Short implants, GBR, and using a tilted implant. But as you know, according to the epidemiological study, if we have less than 10 millimeter in terms of the implant length in the posterior side of the mandible, you can have some problems for a long-term survivors in terms of the bone resorption. Otherwise, if you can place a long implants, tilting the implants, you can avoid this problem. This is the important thing.
So I would like to ask about the surgical part of the implant placement. You said that you do it brain guided. So you raise the flap, you look at the anatomical structures, where do you have enough bone thickness, and you place the implants. So how do you make sure that you are doing it prosthetically driven implant placement, not just bone driven implant placement? So do you have a guide based on a wax up or tooth setup that you use?
Yes, obviously you need to have the wax up, the full digital workflow. So using the video of the patient and using the picture of the patient with, for example, the DSD digital smile design, we can create the preview of this project, obviously. But it's very important the correct implant placement in terms of the emergence, because if you have a not good emergence, you can do this result in terms of the aesthetic of the function. But obviously you need to have the OPG and the CBCT for the surgical procedure. You need to have the impression before the surgery, you need to have the picture and the video in order to make the virtual plan before the surgery. And in order to show this case also with the patient, with the smile line also, the height of the bone, the height of the teeth, and the amount of the fake gingiva.
Doctor, thank you for your presentation. I'm here, right here.
Okay, sorry.
I was wondering, looking at your cases that you presented, some of your implant placements were treated as immediate placement into the extraction sockets. Do you ever graft the jumping gap with any bone substitute materials, or you just leave it to heal on its own?
Okay, this is a nice question. In a lot of my cases, I place the implant in the fresh sockets after the extraction. Obviously, we need to prepare the patient with the antibiotics therapy at least 3 days before the surgery in order to reduce the bacteria inside. And after that, you can place the implant at the same time. And if you have more than 2 millimeters between the implant and the buccal bone site, you need to place the bone. You can place the autolog bone if you have the possibility to harvest the bone, or you can use the heterolog bone, but not for the osseointegration reason, but only for the aesthetic reason, in order to keep the volume, in order to avoid the bone resorption. Especially, for example, also in the aesthetic zone, if I need to place only one implants, after the extraction, for example, in the aesthetic zone, I remove the central incisor and I place the implants at the same time. It's mandatory to fill this gap with the bone in order to keep the volume. And also you can keep the volume of the soft tissue using the immediate restoration. This is another indication of the immediate restoration, the maintenance of the coagulum inside and the maintenance of the soft tissue volume.
That's it. With that, Dr. Kadirali, I would just thank you, and on behalf of the KDA Association, I would present you with the certificate of appreciation. Everyone, please join me in thanking Dr. Kadirali for the presentation.
Thank you. Thank you very much. Thank you. Thank you.
Cover the prayer time and the lunch time. The lunch time going to be in level 1 and Masila 2 hall. Okay? Masila 2 hall. Thank you very much, everybody.